Hello everybody, this is Dr. Medicine RX and in today's video we'll be discussing about Purpura fulminans. So Purpura fulminans is an acute purpuric rash that is characterized by coagulation of the microvasculature which leads to purpuric lesions and skin necrosis. So the basic pathology here is going to be occlusion of the microvasculature or microvascular occlusion because of formation of certain thrombi which leads to extravasation of RBCs and purpura formation. Coming to epidemiology, it is seen in all ages, so it affects all age groups such as the neonates or the young adults or even older individuals. And there are three types of purpura fulminans, of which acute infectious is the most common type and idiopathic purpura fulminans is the rarest type. Coming to etiopathogenesis, so the basic pathology here is going to be occlusion of the microvasculature because of formation of thrombi. As a result of this occlusion, there is going to be hemorrhagic necrosis of the skin. So it is of three types. The first one is the neonatal type. It is associated with hereditary deficiency of the anticoagulant proteins such as protein C, protein S and antithrombin 3. These are major inhibitors of the coagulation system. As a result, there is deficient fibrinolysis and formation of thrombi. Next is the idiopathic purpura fulminans. It is thought to be a post-infectious autoimmune disorder that is following an infection. Autoimmune antibodies are formed which initiate a febrile illness. So these autoantibodies are going to be against the protein S. So anti-protein S antibodies, and this protein S is also required for the functioning of protein C. So there is going to be a relative deficiency of protein S and there is going to be deficiency of fibrinolysis leading to hypercoagulable state and thereby formation of thrombi. Coming to the acute infectious variety, it is the most common type. So it occurs in severe septic patients as well as in necrotizing fasciitis with a predilection to certain infectious agents such as Streptococcus pneumoniae, meningococcus and varicella. So here the bacterial endotoxin, it triggers the consumption of protein C and S and also antithrombin 3 causing an acquired protein C deficiency leading to procoagulative state. Now coming to clinical features, so the patient is going to be completely toxic, that is they are going to be acutely ill with fever. In neonatal type, the manifestations are seen early in life because it is due to hereditary deficiency of the coagulative proteins, anticoagulative proteins, and as a result of this there is going to be massive venous and arterial thrombosis that is visible within 5 days after the birth. Coming to the purpuric rash, it begins with erythema which develops irregular central areas of blue-black hemorrhagic necrosis. There can also be presence of vesicles and bullae, and the affected skin initially is painful and indurated, but in the latter stages there may be a total loss of sensation. Hemorrhage occurs from multiple sites and tissue necrosis and ganglion formation occurs, and this necrosis it may extend to deeper tissues. Coming to complications, secondary infection in the necrosed and the gangrenous tissues, septic shock, hypotension, end organ damage which manifests as hematuria, oliguria and respiratory distress, DIC that is disseminated intravascular coagulation and circulatory collapse and eventually death. Coming to investigations, a thorough clinical examination and history taking is necessary. Taking history about any infections or any protein deficiencies that was already diagnosed or splenectomy, anything should be taken into consideration, and there is a need to look into the complete blood count for detecting any raised WBC counts because it is seen in infections or the platelet deficiencies and whatnot. There is a need for coagulation profile and specific levels of free protein C, free and total protein S and antithrombin 3 are necessary. Liver function tests and renal function tests are necessary to detect any end organ damage. Coming to management, supportive care, collective fluid and electrolyte imbalance should be corrected, and replacement of blood and deficient factors and platelets is necessary. So fresh frozen plasma transfusions for protein C and S deficiency are mainstay of treatment. Platelet transfusion in case of platelet deficiency, heparin and warfarin for anticoagulation, broad spectrum antibiotics if acute infectious purpura fulminans is suspected, intravenous immunoglobulin therapy if there are any toxins, bacterial endotoxins or even immunoglobulins that are formed against protein S, and also debridement and dressing of necrosed areas is necessary. Thank you. Subscribe for more.